let's start with apologies. So Councillor Owen sent us apologies, Karina Ellis, Amanda Bloor, Matt Dukes, Rob Walsh, Richard Flinton, Rob Waltham, Ian Floyd, Julia Weldon, Charlie Jeffrey, although Phil Mettam is representing him. I understand Councillor Shreve won't be with us today, and I'm now assuming that Michael Harrison won't be with us today either.
No, Louise is here.
And Louise is deputising for Michael. Can I ask you then please to introduce yourselves? I'll start with myself. My name is Sue Symington and I'm the chair of the Integrated Care Partnership and also the Integrated Care Board.
I'm Phil Mettam, working with Professor Charlie Jeffrey as part of the Futures.
Gary Senti, head of ECSE for the ICB and presenting on the community transport agenda item level.
Hi, Jack Lewis, public health consultant at the ICB.
I'm Louise Hurst, Director of Public Health for North Yorkshire, here for Richard Flinton and Councillor Harrison.
Hello, I'm Councillor Richard Hagan, North Lincolnshire Council, and I chair the North Lincolnshire Health and Care Partnership.
Good afternoon, Pete Thorpe, member of the executive for ICB.
Jake Abbas, Deputy Director for Population Health Intelligence with the ECB.
Councillor Linda Chambers, Chair of Health and Wellbeing Board and Portfolio Holder for Adult Services and Public Health.
Hello everyone, Rikshan Ramratan. I'm the Director of Adult Health and Social Care at East Riding.
Hello, I'm Han Kenyon. I'm the Place Director for North East Lincolnshire.
Hello, Oka Daly. I'm the Place Director for Hull.
Sarah Story, Corporate Director for Adult Social Care Integration at York, and I'm also here for Ian Floyd.
Thank you.
Hi, Alex Seal, North Lincolnshire Place Director. Katie Brown, Director of Adults North East Lincolnshire, here for Rob Walsh.
Stephen Eames, Chief Exec, ICB.
Thank you. And I'd also like to introduce Denise Horton. Denise Horton is someone that I met in Leyburn, very interested in health, rural health, and very interested in patient transport. So I suggested she come along and observe this meeting. If you're comfortable there, stay. But do you know what? There's room at the table if you'd rather come and sit at the table. Up to you.
That's okay.
Well, you can pretend to be Councillor Shreve at some point. See how that goes. Good luck. Are there any declarations of interest anyone would like to make before we get going? Nothing new. So let's just go to the minutes of our previous meeting. I'm just going to turn the pages and I'm going to ask you at the same time for any matters of accuracy and any matters arising from these minutes which don't appear on our agenda later. So let's start page 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. So we're accepting those minutes as an accurate record of our previous meeting. We do have one matter arising around progress update on children and young people, the Start Well element of our work. But I think that Phil is going to pick that up as part of the Futures group. So I think the most practical thing is go directly to item 7, and Phil will include both in his update. Can I just ask before we do that, are there any matters of any other business about which I should know or which you'd like to share? No? Okay, thank you. So Phil, shall I go to you, an update on the Futures group and also particularly children and young people. Let me just, for those of you who perhaps aren't so sure what the Futures group is, this meeting, the Integrated Care Partnership, should be where we all come together across the system in the interests of the health of our population. And we find ourselves torn often between the here and now and things that we know are the long-term things that we must do for the future. And just to make sure that we carve out a very, very unique space for our future thinking, we run on the same day as the ICP a Futures group chaired by Charlie Jeffrey, which thinks about what are the long-term things we might and should do to improve the health of our population and improve health inequality. And it's this group that I've met this morning, and Phil is going to give us an update. So over to you, Phil.
Thank you. Good afternoon. So on behalf of Professor Jeffrey and the Futures Group, 2 updates for you. You'll remember and you've heard previously about the first programme developed by the Futures Group, which was predominantly focused on children and young people. I'll ask Pete to expand on progress with that in a moment. It's moved to exploring proof of concept stage, so good progress to report. Also some progress to report around the second area of interest, which has been focusing on healthy ageing and longevity. And the Futures Group, with your support, would like to move to a phase over the autumn and winter to develop a proposition for you next spring, which I'll expand on shortly. But before I do that, Pete, would you mind updating on programme 1?
Yeah, certainly. Thanks, Bill. So just to re-centre that, why are we looking at children and young people? The basic premise of this is that if we can join up health and care data with education data, we will be able to have far stronger interventions for specific groups of young people and get upstream of failure, basically. So we're in phase 1 development this year. There are broadly 3 parts to that. One is to create the core data infrastructure. You want to know about core data infrastructure? Jake has all the details on core data infrastructure. Got significant strides around how we join up our data environment in a way which allows us to gather information together. Secondly, to take this forward to the full business case. And the 2 areas, possibly 3, which we're looking at for the pilot studies. One is building on the born and bred in approach, famously started in Bradford. What's different in Humber and North Yorkshire is nowhere in the country has attempted the scale that we're attempting here. So that's putting us on a national map. More precisely looking into early autism detection rates. I don't think we've got a SEND inspection in any of this area where early identification of autism hasn't been an issue for us. So that's quite exciting. And then through some of our national contacts, we've had an inquiry around how we might do more to think about children's mental health and resilience through that project again. So we haven't formally adopted that as one of our pilots, but we are looking into whether that's feasible. That might have to come later on.
Thank you.
Thank you, Pete. So just to remind ourselves about the ambition that's been set for the Futures Group, so the bar's high. So what can the Futures Group do that will develop sustainable transformational impacts that will last a generation? So we're thinking 10 years, not 1 year. So if we think about what Pete just said, that's the aim, so that in 10 years, the ICB will be able to look back and see the changes to the lives of those children and younger people, and specifically around that proof of concept, how the experience of those with autism has changed during that period, not just them, but within their families and communities. So that was the first area of work. The second is different. And the second aligns with the political window of opportunity that we have at the moment with the changing administration and the report that's recently been issued by Lord Darcy, thinking about prevention, digital and community. So what the Futures Group would like to do and would like your support in taking forward is to focus on healthy ageing, longevity and older people. The Futures Group spent probably most of the summer and previous spring thinking about how to do that. And there isn't a Bradford to copy. So that's made it more difficult because doing a big Bradford has been helpful to us in terms of scale. So what the Futures Group is resolved to do is not immediately mirror that and think about scale, but to focus instead on coastal towns where there are particular elderly communities that are hard to impact in terms of the quality and length of their life, both older people and the families and communities that surround them being impacted in a way that will sustain a generational change. So what the Futures Group would like to do is initially take forward a piece of research, that being non-traditional in its concept. So it would like to take forward something called a living laboratory. where small communities, so let's say between 10 and 20,000 people, and within that the elderly communities, start to experience their future but in the here and now. So testing ways of giving them confidence about their own lives, how they live their lives, and how they network with other people. So that will be about the environment within which they live, the communities that they operate within, and the technologies that may be available to them that over that period will change and give them opportunities to be more confident about themselves and any diseases and morbidities that may develop during that period. So what we want to be able to do is over the autumn and winter, co-create in, we think Scarborough, we think Bridlington, and we think Grimsby Cleethorpes, co-create with those communities ways of doing that that will develop that living research methodology. So that as we get to next spring, this ICP and the ICB will receive a proposal that takes forward how we can bring about that generational change that will sustain a decade in the same way as we're trying to achieve through connected health and that digital opportunity that Pete talked about. So key to this will be all of the partners around the ICP table that are not the NHS. So this will be about place, it'll be about local government, third sector, it'll be about taking risks with private sector investment, and it will be about trying to find ways that work in those communities that we might not necessarily believe, but they think it's the right thing to do. And so this will be about the NHS taking a step back, but supporting and helping maintain momentum, but letting those other partners build that momentum within communities so that there is trust amongst those older populations to, over a period of time, consent to allowing us as partners to work with them to transform their lives, make their lives healthier and longer with their families and in their communities. So a different way of trying to get to health inequalities in our coastal towns, and for the first time meaningfully get to that deprivation piece that certainly over the last 15 to 20 years, the NHS in its more traditional ways has not yet been able to achieve that sort of improvement. So with your support, that's what the Futures Group would like to do. Over that period, that's likely to involve a number of workshops. Some of those workshops we would like to hold in those places so that it's meaningful to those people who we want to work with. Hopefully, as we get to next spring, that will lead to a proposition that this ICP and the ICB will be excited by and will support in terms of taking forward something that will lead to a meaningful change for those families that previously we've not been able to get to.
Thank you, Phil. Very timely, isn't it, as we listen to our new Secretary of State talk about his left shifts, which include very much technology. Any questions for Phil? Yes.
Yeah, and I don't understand the rationale, Phil, of asking the NHS to take a step back, because I would have thought that they were an absolute key partner in terms of developing a different way of working for older people. I've got a vested interest there, becoming one.
As many of us probably have. Yeah, really good question, thank you. So stepping back in terms of not assuming that the NHS knows all the right answers and therefore should assume a leadership role. So for example, we were just discussing this morning within those communities how you would segment the population. So if you talk about, so the NHS talks about risk stratification, which is a bit technical and quite medical. And the NHS does that in a particular way, and it's done it for quite a long time to different degrees of success. But if you were if you were to talk to a housing association or to local government and or the third sector and or help the aged and those communities, and you asked them what they would say in terms of, well, what are the risks? They would probably come up with a different framework of opportunity to the NHS medically dominated approach to risk stratification. So that's an example of why we would want the NHS to just withdraw sufficiently to not think it knows best.
Yeah, thank you.
I think Gary's next.
Thank you. It's not a question as such, but for the last year or so, we've had a research engagement network, which is effectively working through BCSE organisations along our coastal strip to engage communities and to get them research ready. So we've had that in place now for, I said, nearly a year. It's been NHS England funded, but it's kind of come in spits and spots. But we just have had the most recent funding round that's gone by, so we're successful for the next 6 months. So if there's anything that we can do to connect that, ready for your proposal, but there's already several VCSE organisations engaged in that.
Great, thank you.
That sounds
Did
like
we
a
know
good
that,
connection,
Nikki?
doesn't it? Louise.
Yes, thanks, Phil. And just to say that the Director of Public Health report for North Yorkshire this year is going to be on healthy ageing. It will be published before Christmas. And we've got a healthy ageing plan for the county, and the key issues are around health and reducing health inequalities. And when we look at our top 10 wards with people over 65, which is over a third of people in the wards, 3 out of the top 5 are in the Scarborough area, so the coastal communities. So we've got some intelligence here, Phil, that we can certainly feed in. But the other issues beyond health and reducing health inequalities and health in its broader sense is around housing, employment and financial security, and making North Yorkshire an age-friendly place. And you know, it's a really positive to actually live in a beautiful county. I'm speaking of a resident in the room who hopefully would say that, you know, there's really big opportunities in our coastal communities as well as challenges. So we have got asset to build upon, and we've certainly got some people in our community who I think would certainly come forward and co-produce this work with us, and we can be a conduit to helping to connect together the people that we might want to talk to.
And that co-production piece is absolutely vital to making this stick. It's easy to do something that's an initiative.
Yeah.
It's making it stick. So the challenge, the test is a 10-year transformational, sustainable change. The only way we will get to that is to do it with, and we can't do that without those of you in places with your partners helping design that. That's the only way we'll get to something that is authentic to that community.
And this is important for North Yorkshire, isn't it? But I don't think we've got North Yorkshire Place here. So can you make sure you feed in that information? But did I see your hand, Helen?
Yes. Yeah, I suppose they're just building their connections really. And I guess some of the work that we'll need to do that will flow out from this, Phil, I think will be linking strongly in with the development of our integrated neighbourhood teams and how they support. Because of course, what we want in those to be is multifunctional, multi-organisational hubs that coalesce around geographies and communities and can support in quite a different way, and then creating around them and what we call a team of teams. We're all looking at that, those more specialist bits that you perhaps wouldn't have in every team, but the team will need to link into around. If somebody's gone out and they find somebody with a really bad housing, actually what do they do about that? It is that shift from I'm going in to do a task to thinking about I'm going in, and as part of that I'm assessing this person's needs and making those right connections. So I think through some of that work, if we can build that into some of the future development of the integrated neighbourhood teams as well, I think that would be really beneficial and should get us even further still.
Yeah, thank you. And what we may find is that in those 3 places, because of in part the geography, but very much because of the partnerships, the approaches may be different. So part of the value proposition from a research perspective is helping us then learn and understand that different things might work in different places, and not to assume that things are automatically transferable, because these communities will be very different. They'll have their own distinct differential, and we have to get to that to make it effective.
Yes.
I think we're going to have to be really careful how this is. I would hate, looking at the way old people are feeling at the moment, I would hate it to send out the message
that we're stepping back, that we don't care. I have a difference. I think we need to be saying, we're trying to get you what you need.
Yes.
And everybody has a different need. And by having different needs and we've got different providers, and you're more likely to get what you need and what you want. So I think we've got to be really careful with the way this is a trade.
You're right, Linda. You're right. But it is pivotal, isn't it? The more we can educate all parts of the population to help themselves increasingly, the stronger we will be in our endeavours. So I think we approve. I think we're happy that you go ahead and do that. And I think we very much look forward to hearing more about that in due course. I'm going to move on to item 8. In spirit of partnership, generally, Councillor Owen, who co-chairs this meeting with me, would provide a 5-minute update on what's big in local government at the moment. I don't know if anyone would like to, on the spot, just reply what the big issues are in local government. What would you like to say?
It's going to be budget setting
Sarah.
for everybody. So budget setting will be on council's minds, and that will be, the biggest part of the challenge over the next couple of months as we get into uncertainties around what the settlements might be this year, and not knowing whether there's going to be sufficient growth there to meet already depleted budgets. So council officers have a very strict time to work as we go through that. But certainly in York, and I know a lot of other places, we're really trying to work hard with our communities and partners to engage and get those great ideas from people about what we can do differently and think through how we manage those resources differently. It certainly just focuses the mind and attention as we get into the York. So.
Okay, lovely. Thank you, Sarah. We are getting the note. There is no money mantra, aren't we, all of us? Brick Chant.
So other than money, I just want to emphasize it is just disappearing. But I was going to make a comment around kind of how we do this. Really, the co-production is very, very important. But as is really deeply understanding the issues in each of those areas that we're trying to do something. So we've been sort of doing quite a bit of work around prevention. How do we make sure we don't do the same things as we have been doing in relation to prevention, and particularly around public health, particularly that may not be delivering everything that we need, largely because we've got to try and kind of bend some of that towards the need of the population in different areas. So yesterday we were just hearing from Simon about the kind of additional community diagnostics that's coming in, and one of the challenges we've got is that many people who live in some of those areas don't access it as much as other people do. And that lack of access isn't to do with rurality or transport. It is much more complicated than that. It's about people's expectation of their own health outcomes that people don't engage in that. So really you've got to do a bit of detailed thinking about how do we engage those pockets of population, and how do we really kind of do a different deal on prevention. So this is from a discussion yesterday that Councillor Owen was sharing. And we've got to really have a think a bit more in more detail about how we're using all the monies that are available to us, and certainly it's a big collaborative effort that we've got to make.
And how we use our money together.
Absolutely, that's the other thing I was trying to get at, so including public health monies, and it's a big topic because Canada Care doesn't have all the money that it needs, nor does the NHS for that matter. So we've got to really try and how do we get the best outcome for the money that we are spending?
Absolutely. Councillor Hannigan.
Yeah, I think that both in Greater Lincolnshire and Humber and East Riding, the devolution is going to be very much a priority on our agenda, as those deals have just been approved. And I think for the area south of the river, one particular challenges in terms of health, of course, is that we're on a different footprint to the ICS. But with that said, we've already got a proven track record of working across geographies, and I think we just have to embed that cross geography working and not let it become an issue. Just work your way around it. I know that sounds really simple. It's there. It's an issue.
There's a river in between the two.
There always has been.
Yes, exactly.
Whether we call it Humber side or whatever, there's always been.
I'm agreeing with you.
Well, the Humber Bridge, of course, you'll have to remember, is 18 feet short. Speaking as the chair, then I've got nothing interest there. For ourselves in North Lincolnshire, the economy is a key issue. We're highly tied to carbon hungry industries, and decarbonisation is going to be key on our agenda again. But with that comes many challenges about getting inward investment up front to do that piece of work to keep our economy flowing as it should be. And I think the other key issue for ourselves, and it links very much to what's just been spoken about, is housing. I know that both in North and North East Lincolnshire, the home choice links, the means of allocating social housing has just come under review. And what has become clear from that is that there is a shortage of suitable social housing. And I think that that's going to occupy our minds very much as a priority over the next few years.
And it's of interest to us too, of course, isn't it?
Absolutely. It is.
Katie, did you want to say something?
I was just going to ask if any of the Humber councils wanted to discuss Devo, but that's already been done.
Stephen.
Yeah, well, I was going to, even Richard mentioned, I did say that's a pretty big thing. But if you extend that for a moment, I want to come back to what Sarah and Chand were saying to do, and what you were saying about there being no money in a second. But just on that, which I think we were sort of predicting, but we do have 3 combined authorities, one that's more advanced than the other 2, but nonetheless, I'm sure we'll catch up very quickly. And I think that's a key vehicle for this new government. I think it's really clear that's a key vehicle for this new government. I think we probably all are. So we're in quite a good position, you might argue, if we can, work with that, particularly through the leadership of local government colleagues. I just land that. I mean, it seems to me that's the business of this agenda. Go back to the earlier point. I think I'm going to say, I know why we're saying there's no more money, because there is no more new money, although let's wait until the budget. What I worry about from an NHS point of view is that suddenly we find a few £1 billion to sort out the deficit. Oh, that's all very well now. We can all sort of relax. That I think there's a serious danger that's going to happen. That's a strange thing to say, doesn't it? Because we can always welcome more money. But I suspect that could happen. That's the usual short-term sort of knee-jerk reaction. The thing that I think you raised it first, Sarah, and then you see there's actually an awful lot of money already being deployed, and I hesitate to use my York example. I can use my North East Links example if my numbers are right. But we've got small amounts of money in Section 75 agreements, yet huge amounts of money just in the NHS spend. Hundreds of millions in each of our patches that could be in those agreements. And we've also got the proposition through Darcy, which is hardwiring financial flows in that direction. I wasn't going to bang on about any detail, but if you come back to what's this forum for, I think it'd be really interesting, and I sort of commissioned this from Alex informally earlier. Do we understand around this table what the totality of the opportunity is financially? Because I was sort of reminded at this time last year, other colleagues, some are not with us, we did attempt, I think, to bring a resource picture together through the sort of. I don't. We sort of got, and that's not a criticism. We sort of got there. But I think we really need to know how much we could put into that pot. There's 200 million. Is that right? I keep saying that, Helen. Correct me if I'm wrong. Going that pot in York, it's 330. It's 37 million. But I quote my York example again because there's 337 million we could put into that if we were bold. So I don't want to bang on about it, but just to say that if we could see the totality of that, connecting to your point, Richard, about then, what does that look like if we're thinking about cross geography and there are 3 sort of subsets, are there, of the geography? If you look through the combined authority lens, that's I think what we should be doing here. Really over the next few months and beyond to reach that next planning round that you're talking about.
Thanks, Stephen. And then in return, we generally do just a very brief update on what's going on in the ICB for the benefit of our council colleagues. And I can be very brief. Not so sure about Stephen. Oh. I'll kick us off. And of course, the change of government has been really, really significant for us. The sense I think across the NHS is people broadly welcome West Streeting. I think that's been the general view. I think there's a general view that there've been a few own goals. I think removing the heating allowance for pensioners probably not smiled upon particularly, and I think there's a question mark about who would pay for a 22% increase for doctors. We haven't yet heard about that, And now we learn that the nurses are not accepting their pay deal at 5.5%. Well, there's a surprise. So there are a few misses, aren't there? But actually, I think overall we're welcoming Wes Streeting and his approach. We've had the Darcy review, which we always knew was going to be step one. We're waiting for step two, which I think is the budget on the 30th of October. Then we'll know a little bit more. But the real acid test will be the 10-year plan, which is going to be published. Well, there isn't a date yet, is there? In the spring, or maybe early spring. So, I mean, I think if I was in Wes's shoes, I'd be doing the same thing. I'd be taking my time a little bit, listening, watching, learning, thinking. But certainly that 10-year plan is clearly a very big deal. What we've learned and what we've heard about through Darcy is very much aligned with the work that we're doing. So we're absolutely not out of step in this geography. And the Darcy work is very much aligned to the purposes of ICB. So that feels about right. So that's our bigger picture. The only thing that I would add is the thing that I said at the beginning of this session. It is the government's view that these integrated care partnership meetings are the epicentre of the partnership between local authority and the health service. I have, and Steve and I have both spoken to the local authority chief executives to say we absolutely need not just their kind commitment from a distance, we need them in the room, because we need to make decisions that we together collectively. So I'm going to be redoubling my efforts now over the course of the next 3 months or so to make sure that we achieve that. And I'd be grateful if all of you, in your own ways, could stress this urgency, please, to your local authority partners. And this business of, we've been working up, haven't we, towards a time where we might be able to share resource, share money, share people, work together in a different way. We're there now. So we need everyone back in the room. And we want to be looking shiny when the government look for integrated care partnerships who are making this stuff work, not as if we're a struggling partnership. So an unusual thing for me to say in this meeting, but I want to say it and I want it to be minuted. I think it's really important. Stephen, you might want to go on. Go on.
Now that's two hits now. So I'm going to say three things really quickly. So I guess really, some of the things I might say more about are on the agenda later, around the place reports and the design for the future item that we got on the agenda. So the three things are short-term priorities, winter and money.
Yeah.
That's no different. Oh, and I might add to that, I suppose the 40,000 reduction in waiting list the government has committed to. So those are the sort of three immediate short-term priorities. The only thing I'm going to add, and I know I mentioned it earlier, and I think this shows that we've got a health secretary who gets it in terms of what you've just been talking about. The biggest announcement in his speech today, and it very much features Humber, is sending crack teams of clinicians and others into Penlag and Hull in order to focus down. And the reason for that is that along with 7 other places in the country where you've got a lot of people who are off sick, basically in the community. So this is tying health to worklessness to growth. That's what I think that does. And what those crack teams will be focusing on is getting people back to work, as well as actually clearly addressing the waiting list. That's the biggest announcement today in what he has said. So that really directly impacts on our 2 of our local communities. My point earlier was that's acute health. We should be thinking about how we do something like that for mental health, and we should be rolling it out across. There's another massive quick connection with the ICP. Really, everybody's got a common interest in getting people back to work and the upstream prevention around health at work. Anyway, I was going to say any more on that, and I'm going to hand back to you, Chair.
This is an opportunity for those who don't get to see Stephen very often, or me for that matter. If there are any questions you'd like to ask, we're always willing to try.
I mean, just to go on, really interesting what you've said there, Steve. I wasn't aware of that.
But only just been announced this morning.
Yeah, and I suppose from a North Lincolnshire perspective and working very closely with NLAG, they talk about the difficulty of recruiting into the area. That's always been a key issue, of recruiting key skilled staff into the area. And I just wonder if another spin-off from that particular issue that we've spoken about is that at least in the short term, those recruitment problems might be eased, and that we get the specialist staff that
I
we
can say two things about that. And to be fair to NLAG, and I think and I think you could extend that across to Humber. I think they've done amazingly in that organisation in terms of overseas recruitment into consultant grades. So one of the big problems around emergency services is this acute physician model that the Royal College of Physicians have been promoting for well over a decade. And that's about a generalist working alongside the ED specialists at the front door without going into details. We've got 12 in NLAG. That is amazing. It's far more than anywhere else. And that's, so I think they do well. It's just a point I want to make there. And again, I don't want to sort of go into what Peter might be covering later, but in order to deal with the recruitment of professionals, we have to change the configuration of services, because we'll never recruit people to services that are hanging on by by the tips of their fingers, very fragile, can't provide training. I mean, it's all that sort of territory. So that's the other bit where I think we've got some ways of potentially improving our recruitment. The last thing, I know we talk about this a lot, is we just have to work harder at promoting how wonderful it is to come up working in our places. And some of the inward investment, there is in North Lincolnshire, for example, I suppose gives us a collective responsibility to do that.
I think likewise, if we get integration right, that
agree.
Improve recruitment too.
I agree. Yes, Sarah.
I was just going to follow on with that. I was thinking about, there was an article in the news earlier. I was thinking about the difficulty in promoting how great it is to come and work for the NHS and local government when we hear such.
Well, it's the same in North Yorkshire, to different degrees.
So that really, really kind of negative of a broken NHS at the minute. And I was just going to say, how are our people? How are our workforce? How are we kind of keeping up morale and supporting people when it's been really difficult for ages, hasn't it? But it feel particularly difficult when you feel a little bit pointed at and criticised.
Yeah, we've noticed that. We've been doing a string of staff roadshows this last couple of weeks, and I think people do feel a bit worn down by that. Broken, not beaten is what we hear, isn't it? It's not great, is it? On the topic of recruitment more broadly across the geography, these are other things that we could do collectively, aren't they? And we probably need to think about doing collectively rather than individually, and we probably get greater bang for our buck if we did. I'm going to go now to Peter and to Alex, who are going to provide us with a place update. Thank you.
Okay, thank you, Chair. I'll start and I'll tee Alex up. I think the first thing I want to make a point on is in our strategy, the document that we sign off as an ICP, as a statutory responsibility, we made two significant commitments. One was to empower collaboratives, provide collaboratives, and we're making good progress on that. The entire mental health budget's been delegated into the collaborative, for example, from next year. And the second commitment we made was to establish a new relationship with places. And we had some conversations at the time about what do we mean by that. We talked about place deals. And I know you know this, but place is all about trust, shared endeavour. It's our opportunity to integrate our services around population of need, to meet the need at the lowest level, and that's across all healthcare and general well-being. So I know we know that, and there is a real prize in getting place right. I think we all commit to that. When we do that, we then reset the purpose of the ICB and the relationship that we have with places. Now, all of that needs to play out, and it's still moving. But at the really essence of it all is about distributed leadership. So as an ICB, not trying to run from the centre, not trying to run as a regional health authority, but being the organisation that helps coordinate that distributed leadership. And part of that is the shift in resource, people and money and decision making closer to where the action is. So whether that's collaborative or place. And the vehicle for that is the joint committee and Section 75 agreements, but they are just the vehicle. They are not the prize. The prize is in what we do for people. So there is already a strong history of this. I mean, we're not starting from scratch. Every place has Section 75 agreements. Only North East Lincolnshire has a joint committee at the moment. But to scale some of the Section 75s in places without a joint committee yet, I think Erica Hulls is in the region of £86 million of full NHS and local government money already. Could be a question about why we haven't got a joint committee there. But we can see that that's already working. So we're working on some success. However, we should probably be equally excited and have a sense of trepidation about stepping forward into this, because we are setting up relationships where we will either pool money, so pool it as in put it together, take the organisational tag off, it's just public money, or we will align budgets. There's still the accountability to the organisation which is aligning those, but what we're doing is we're sharing the influence to make the decisions. Now all of that means you're not doing it for 1 year, you're doing it on the basis of this is a relationship we're entering into for the long term, because all of that money is being spent and probably being spent on some reasonable things right now. But over the long term, as we understand our populations and our needs and where our assets are in our communities, we can start to morph some of that over time. There are some tensions in there, because some of the having brought 6 places into one organisation as an ICB, one geography, we are exposing a very significant amount of inconsistency in terms of policies across it. So we're kind of trying to equalise some of that, and at the same point let go and give away. So that's kind of teeing it up, and then Alex is going to tell you about where we're at with individual places.
Do you mind if I just say something briefly about that? Sort of connecting. So if you then play that back to, if you like, refreshing the ICP based on where we think the Secretary of State's going. So if you go back to that point I made when you were President, last we were just trying to understand what the money was last year. So we should better get there quite quickly. In other words, the money that's that underpins all of that is a collective picture of the total, at least of our 3.9 billion. It'll be a lot of it. You then into some choices about how you spend, and this brings us into the difficult territory of needing to spend more on some things than on other things, or in some geographies more on other geographies, which I think we talk about a lot, but we're not. I think where we're going with the national vision, joined up, I mean, beyond the NHS, it's taking us firmly into that territory. So I'm just saying that it feels right for populating this agenda going forward with that sort of stuff, with some sort of difficult choices and issues to talk about in that context. That might also respond to who we have at the meeting. Yeah.
Richard.
As Peter was speaking, I was kind of reflecting on some of this really. My worry about this is that it appears that we might be speaking about some of those ways of working as if it was the first time. We've been on this journey for about the last 30 odd years. And there's been, I mean, I've been around trying to do that for the last 30 odd years at least. Mm-hmm. And what my worry really is that I think money is one thing, but I don't think it's all about the money. Some of this is about ingrained sort of kind of institutional, I would say, biases in different organizations about how we discharge our responsibilities. And some of that is going to take some doing to shift. Yeah. Because that's what stops us. Yeah. It's not the money or the kind of the people. It's much more about how senior people behave.
Well, it's also true. Yeah.
It's cultural. So there's an element of sort of thinking about what support staff will need around change and kind of working slightly differently, different rules. And the other bit around, I think I agree with you that I think variability is not a bad thing because their history, they're different in each of those areas. History of joint working are different. So some element of variability is not unreasonable. And I think there are easier hits on some of these things. So things like how we engage and commission from the voluntary sector is a really good example that it's been an open door for a long time. If we understood what each of the organizations, and I would say wider than just kind of adult social care and health, but police, probation, and everybody else. So trying to really proactively work with people. we'd get better results. But it's been an open door, and we're not going there. We're not going there because we've got really deep-seated biases that we probably don't get to talk about. So the community doesn't get populated with what the community health should look like, because we can't change the minds of senior leaders who really need to be doing their business out in the community. And that's a bit we need to get at. And that applies to both local government as well as the NHS.
It's powerful what you say, Brooke-Chan, Pete.
No, they're well-made points. And I think there's some variation is definitely to be embraced. There is unwarranted variation, both in inputs, but there is definitely unwarranted variation in the outcomes that people achieve across our geography that we do need to be really mindful of, which talks to Stephen's point about we may, across the whole, have to think about our investments in a different way. And whilst we're sort of getting to the truth of things as well, we have to ask ourselves some searching questions around why, as we have been going at it for a long period of time, what would we need to take us to the next level in terms of place leadership? And there is some interesting work going on in different parts of the patch around challenging this sort of notion of radical place leadership, getting outside of your organisational box. Because a lot of what we see in waste in the system is handoffs between organisations, arguments around who pays for what. It's not seamless to the resident, and so a lot, and partly it's driven by regulation as well. So all of that we have to contend with, and it will take a different type of leadership disposition to move us in the way that you are describing.
Can I give you one example of where that is what is that? So, sort of impacting much more directly. So I just go back to the presentation that Simon did on kind of community diagnostics yesterday. So one of the challenges we've got is that we've got new monies, additional appointments, and we also know that there are traditional reasons why that population will not access it. I.e., there'll be a certain amount of diagnostic that won't be used because we haven't addressed the real issues why people are not accessing it. So we looked at transport. Well, transport may not be an issue. We kind of acknowledge that that issues are very different. And yet, I was saying, well, what would it take then for us to try and do that differently? What would it take? So how could we use that money differently in order to make sure we, instead of having, 70% good access, to have it 80% or 90%? Now, the traditional approach would be to say, well, actually, what is local government doing by transport? Well, that's not an answer, because people are not struggling for transport to go and get their shopping from the local shop. They're not, because they're managing their lives. But it's about different things, the way they're kind of perceiving their own health outcomes, that is saying to them, I'm not going to worry about it, or that I'm not going to access it. So we have to use some of the monies that we are putting out there in order to make some of that happen differently. And I felt that from judging by that conversation yesterday, we're probably not going to tackle it. And I fear for the lack of ambition really to make some of those changes, and that would be sad.
Okay, well, let's not be big before we start. Let's think about what we can do.
Just answer as an example.
Not easy though. I agree. I'm going to move on to Alex. Alex.
Thank you. Yes. No, I think a really good conversation, started on some of the key drivers that are going to enable us to do this. So we've been focusing on the key functions of place as the driver of transformational change. And we think there are three really important components of that, which is around strategic relations, the system, convener and distributed leadership that Pete's talking about, delivery of integrated health and care in the context that Stephen talked about in terms of how do we start to bring our resource collectively together to really drive the change and do things differently. And that is writ large in Darcy, isn't it, in terms of direction of travel and the development of out of hospital. So all the ingredients there to help to drive that. And then population health improvement and health inequalities are sort of one of our big ticket issues to deliver that. So we have our place framework, which the ICP has supported. That talks about how the system works together to deliver that. How do we work through our the sort of flourishing system, smaller ICB, our collaboratives, our places to really drive that change and connect the change together effectively. And lots of the work that we've been doing through the Place Design Group, which sits under the Leaders Forum to drive that change, is about starting to have those collective conversations. So we've been talking about how the collaboratives will work more closely with Place, We now have work going on around community primary and VCSE collaborative, working collectively together with place to drive the change. And the example that I've given in the paper is around integrated neighbourhood teams and the concept of really driving that integrated change, which is really speaks to what Brick-Jan was talking about. Because to do this, we need to be putting our collective resources on the table to be able to support that change. The section agreements help us to deliver that. But again, as big as that is the cultural and behavioural shift and change that we're going to need to do that. Some of the reasons why people aren't looking at that holistic support and management and coordination of people. They're doing their best jobs, but they're doing them in isolation and not necessarily coming together collectively to do that. So this really is about how do we make sure that across primary community, acute sector with less going on in the acute footprint and more going on in that hospital environment, our wider public services, adults, children's services come together collectively to really drive that change around integrated neighbourhoods. We've got work going on we've got some really good examples going on across our integrated care system that are included in the paper on this, but we need to really scale and size this and make sure that we've got all of the collective enablers to be able to deliver that model across here, which will be about making sure we've got defined localities, those 50,000 populations or thereabouts populations across our geographies that help to do that. We talk about the concept of an integrated core offer, bringing together community, VCSE and primary care to start to really shape and deliver that. We talk about aligning the resources, the people, the money to be able to do that and using some of the mechanisms and governance that we have to be able to do that. The principle of having no wrong front door, so we navigate people around the system seamlessly. People get the core offer and support, but very much focused around this is about making sure we avoid that over medicalisation. How do we make sure that we support people as close to their homes as possible and we enable them? And it isn't all about the service offer, it is about all of the other support that people can access to do that and all the things that we can navigate and enable people to do to improve their life outcomes and chances as well. And really starting to remove some of the barriers that you spoke about, Brick-Jan, in terms of seamless care, moving some of those organisational and professional boundaries that start to impact on our ability to work together. If we can do this in a scalable way, we've got a real opportunity, I think, to start to deliver some of the things that we want to do within our outcomes and also address some of the issues that have been starkly identified within the ground review as well in terms of integrated approach. So in practical terms, the Place Design Group is working with the collaboratives to look at how we really drive and change this integrated core offer. That will be a core component of the work that you talked about in terms of design for the future and the future direction of our model to be able to do that as well. So those are the main things I was going to pick out. Happy to take it. I think the scene's been well set in the conversation really that's already been generated, but happy to pick any other questions.
Sarah, I missed you last time around, didn't I?
That's fine. It's just a quick one really, and I've been quite involved obviously in the work in terms of both the group that I talked about and also from a York perspective. Really welcome Stephen's comments around that sort of scale of ambition in terms of let's see what we can get on the table and put together. I think what I'd say is we're people working with people, and we must remember that. So we're human people working with people. We do have variation, and I think what we should be seeking is consistency in outcomes for people.
This is absolutely right.
I think we've got there are places where we can do that by having one way of doing things across the patch, and there are places where we can do that by doing something quite different but hiding the wiring for people to do that. And I think there are conversations for us to have about what works where. I'm SRO for some work under the Urgent Care Board around designing the NDT discharge hubs. I'm going to come tomorrow actually, and I'm going to say principles and outcomes for people a lot, and therefore I'm going to be talking about home first, because I do think if we're going to make any change, if we're going to put any effort into all of this work around place, the delegation, the financial agreements, none of that makes any impact whatsoever on its own. We have to be saying what will this do for people in terms of what will be different for people in our region if we do things differently. And I think certainly in terms of our workforce, wherever we've got any opportunity, where they are what passing each other, going in and out of the same front door, where they are spending time having to decide which portion of that package of care is funded by whom. If we can remove some of those barriers and support our workforce to do the job of working out what the need is and the best way to meet that need, I think we'll have succeeded. And I guess in a nutshell, that's what I'm hoping for out of this work.
Well, two quick, but one's about this. I keep coming back to this forum in a refreshed form, given the reinvigorating of the direction. So, we've got, even though there are differences, we've got opportunities around the table here. So some of these are about how you construct something to enable what you've just been describing to happen. We're not, and it's connected. If you listen to Wes Streeting, because I think he knows what he's talking about in terms of when he says that it's not just about the NHS, it's about he talks about a laser focused perspective on the development of neighbourhoods. You can't do that unless everybody agrees what the neighbourhoods are, that primary care, local authority services and all the other services that are outside hospital align with that, and you resource it. I think you get closer to what you're talking about there. Now, in practical terms, that's the place to do, absolutely. But we've only got one statutory power here, signing off the strategy. We can give ourselves as much power as we want around this table. So one of the things it makes sense for the ICP to do is, are we actually doing that then? Have we got that all in place? Do we know what that looks like? Do we know where we might need to place greater emphasis? We don't, collectively, at least I don't think I do. So that's the point about what we might do. Now, I'm going to use the example, Eric, it's not a criticism because I know you commissioned it. The NOA report on cardiovascular disease in Hull, which if you looked at that, which is one of our 5 priorities, Hull is where it's worse than anywhere else in our patch. What do we find when we look at that through the NAO? We've got a really patchy set of arrangements in terms of intervention from primary care on health checks. Now, if anything was a number 1 priority against that, it should be consistent health checks for every single patient in Hull. And you could say that's probably, there's some on the point about variation. I mean, that you want the same, don't you, everywhere? But then you get if you don't even have the coverage. So a priority would be to say, we're going to ensure, as an ICP in this context, every single person that requires a health check, however difficult challenge it is to get to them, we're going to do. And that's going to have a direct impact on outcomes, isn't it? If we're able to do that. So I'm just sort of pointing up a couple of things about, because I think that a framework's a framework. I'm not. It's all that's all good, but what's the output going to be? So I'm just, both of those things are things that we could, as examples of things that we could legitimately focus on here more effectively than in the ICB, where we don't have the broad range of inputs that we've got around this table.
Erica, just let you make a concluding comment.
Thank you. Just following on from Stephen, absolutely, that sharing of the data and information at neighbourhood level has really been what's instigated some of the conversations around this. And we spoke earlier about our workforce and how they feel sort of battered, if not broken, as well. And this has really generated and energised a conversation in I think in all the places, and it's certainly in Hull where it makes such sense to the people who are going through the door to reduce that duplication and to work differently. And the sort of the common sense nature of actually how we should be delivering the principles of integrated neighbourhood teams has really caught on. And I think there's some real opportunities for us here and a real enthusiasm behind it.
Great, good to hear. Okay, well, let me move on. Those of you keeping an eye on the clock as I am will notice that we are a little bit adrift. So we can attempt in the next hour to win things back. But Peter, item 11, design for the future.
Thank you, Chair, and I'll take the hint.
Thank you.
Well, look, we've rehearsed some words here about the NHS, broken, DASI, critical condition, and we can look to some of the factors like workforce, money, policy, but actually, the essence of what's happened is a failure to meet a population need. So in a presentation we had this morning, the Futures Group, it was observed that whilst we've been talking for years about a left shift, so that more social and community based, what we've actually had is a right drift, and we've had more people ending up in the specialist end, in acute, in a hospital, and that's the essence that I think Darcy is drawing out, that we have to have fewer people ending up at that failure end of healthcare. In the same way as you wouldn't want to have lots of children taken into care if you're running children's services, it's the wrong end. So it's turning that round. Now this system has been looking at this challenge long before the change of government. I think that's the first thing to say, that we've been ahead of the curve here. And we've been working on what we've called the design for the future. It's been loosely called the blueprint. And it's about projecting into the long term how we are going to achieve our ambitions around excellence and prevention and sustainability through broadly two strands. One, how we configure and organise services that the public access, so how people experience their health and care. And secondly, what organisational structures might need to change to enable that to happen as well. So those two have been running twin track. There was a blueprint document which was put together by chief execs, including local authority chief execs from across the system. It was a set of principles that we circulated to say, essentially, one, nothing's off the table, but we really do need to have to talk about how communities, services in communities are organised, which Alex has just talked us through. We need to talk around mental health services, and we need to talk about hospitals. And from taking that document out and socialising it, what's washing back now through that distributed leadership approach that we're working to is these are the outline propositions that we think we could go at. So we think there's some work to do on X or Y, and they're at a very formative stage, but they're giving us enough information to be able to say, right, the conversation we need to have at a very high level with the public looks like this. So there will be a public engagement starting middle of next month under the tagline of "We need to talk about," and we can't get into the fine detail of we want to have a conversation about, I don't know, hospital X or service Y, because that starts to get you into the predetermination stage. This is a very, very high level testing the waters with the public about what matters to you as a resident, so that when we get further down this line, we have got something to start to base our options appraisal on. And what we shall do in that high level public, almost like pre-engagement, is we'll segment some of our audiences. So we target some particular groups which we're interested in, so we get a bit more depth in that. But that will be kind of wiring behind the scenes rather than anything which is up front. So by the time we get to the new year, we should be in a position to, when I say we, this is the System Leaders Forum, which is our authorising environment. We'll be in a position to say, these are now the areas which we have got most to go at, and we will then start the formal processes where they are required to talk to the public through that full process. Some things we won't need to talk to the public about because they are almost the mechanics of how things work, and we won't be removing or changing the service provision. What we will be doing is some of the types of work that Alex has talked about, where actually it's within our gift to just shape a service for a population rather than having to go through a full consultation. So I think probably, Chair, I'll land it there and then just leave it for questions.
Thank you. Thanks very much indeed, Peter. Are there any questions for Peter? Okay, so this is iterating work, and we will hear more about it. And it is shaping the way forward for all of us. So thank you, Peter.
So can I say one thing?
Yeah, you can.
Having said we were ahead of the curve, all of the high-level work which is coming back is absolutely on the button for Darcy. So this system is riding ahead of the curve by at least 3 or 4 months.
Right.
And the expectation is that every ICB area in this context has its own 10-year plan. So this just dovetails in with whatever guidance and direction comes out. And I doubt there'll be anything in that differs from what we've been doing.
Thank you. I'm going to hand over now items 12 and 13 to Jack and to Jake. I just want to say what good papers I thought these were, by the way. So when I was preparing, I was reading your papers, I was really pleased with them both. So thank you. Jack, do we start with you? Now, can everybody, Stephen and I have got a great view of this board. Can others see that one clearly enough, or behind you? Just make sure everyone can see. You're going to use your slides, Jack.
Not too important, but I'll have them on for reference,
Thank you,
and for, of course, people viewing online.
This is particularly important for us, isn't it? This integrated needs assessment for the ICP.
I agree, and actually very reflective of the entire conversation we've had today. So this ICP a year ago, I think in good public health practice said, we're an integrated care system. What does that mean? And what are the needs for integration? What's the evidence base for integration? What are our own perceptions of integration internally? It stopped short of going on to say, what does our population feel about integration? But I think Peter's just picked that up with how we go out to engage with our populations. That's a natural next step. So I'm here now today to report back to you the findings of this integration needs assessment. The three objectives we laid out were to assess the history internally of integration, to look at the need for it internally, and to evaluate the effectiveness of it in various contexts. And we use three methodologies to do that, starting with data analysis, and I'll share some detail on that shortly. Moving into an evidence review, really robust review of the literature, and then finishing with a really comprehensive set of qualitative analysis using interviews and focus groups with our staffing groups across all sectors. The data analysis Jake and I have both brought to this forum in the past, and we've used actually the early work that came out of this assessment, I think pretty good effect. This described the several challenges we have, including our aging population. So on the screen now is a map of where in our system there's an aging population. The second map is of where there's deprivation. And if you flick back and forth between those two maps, apologies to those who have their backs turned to the screens, they're primarily in different areas. And so really important feature for our integration work is considering that when we respond to expressed needs from an aging population, we perhaps risk leaving behind those deprived populations that are in different areas, except on the coasts. So the overlap in deprivation and aging populations exists in our coastal populations, and our futures group has picked up part of that, but obviously needs to be a continued focus. One of the specific requests from the ICP when we first proposed this work was make sure there is a focus on coastal communities. And to some extent, the data we've unearthed has highlighted that where essentially this feature here, where we're talking about integration, there is a special need in our coastal communities, which feature both this aging population and deprivation, widening health inequalities picture. The other bit that it just highlights is the inconsistency in allocation across sectors. So we have about 50% of our budget going into acute, and this is just within the ICB allocations. It doesn't account for, of course, all of the money that is in local authority and social care services. But as Jake and I have been speaking to how we tackle increasing demand for services and widening health inequalities, we've repeatedly pointed towards both prevention and towards a rebalancing of care sectors. So it's important to recognize that part of that rebalancing potentially sits within resources and staffing. This is a picture of our staffing groups that include social care. In the top right there, the big orange box is acute sector staffing and secondary care. And the big box on the left with 50,000 staff in adult social care. These are rough numbers, but we made a point of using publicly available data as part of this needs assessment so that we could go back and repeat the exercise if we wanted to without a bunch of internal information. So when we talk about the need for integration and looking at the quantitative data, and in the extended data pack, I'm not presenting all 60 or so slides, but you all have that now. It goes through what the knock-on impact is to different services And there clearly is a bit of a train track we're on now if we do nothing different, which leads to a acute need for capacity, essentially, if we do nothing else. So therefore, what are we going to do differently? It has to include joining up services to think about the problem together. Which turns me to the evidence review. And when you comprehensively look at the evidence on integration, it essentially says that on its own, it does not work. It is a vehicle for change. It does nothing necessarily independently of the outcomes that it's meant to generate. So a few specifics within that. Larger geographies can lead to inequalities. So focusing on a perhaps ICS level picture misses out on the neighborhoods we've been talking about today, misses out on the places we've been talking about today, where you need to devolve power to make sure that we're addressing health inequalities. Integration can be an accelerant for changes, certainly when you have additional capital applied to integrating IT infrastructure. In most of the literature, it showed that people felt they had improved quality of care and that their needs were better met. So if you think about integrated neighborhood teams, clearly someone who's going through, or a Jean Bishop Center, going through that type of service is going to feel like they're having their needs met. Importantly, though, it doesn't necessarily address demand and capacity issues. So by joining up services, meeting an individual's needs better, but there's an efficiency cost potentially to that. And we have to be really conscious of that. So no piece of evidence said that there was a sustained reduction in cost of care over the short term. And it becomes incredibly important then to make sure we have our key outcomes lined up, which Jake is going to speak to in a bit, so that we're measuring the right things, but also giving ourselves the time and space to see the outcomes we want to achieve. And not necessarily reverse direction, but bend the curve. So being conscious of the first part I was speaking of the quantitative data, things are moving up and to the right. We're not looking for them to move down and to the right. We're looking to bend that up in the right picture. I'll finish with a discussion on the qualitative analysis. So this was a set of 25 interviews with 42 people, really well spread across our sectors, across our places. And thank you for those colleagues in the room who've participated in this. And there's a lot more detail to share with you behind this that you can share with your teams as well. I'll just draw a few points from the qualitative analysis. The first is people in our system felt integration was the right thing to do. But there is not a clear definition of what integration is. Everyone has their own. And you could think about integration as vertical, as horizontal, as resource, as staffing, as buildings. All of it, the same person could say integration. But we have to be incredibly clear that if we want the system to move in a direction, we have to talk specifics about what that means. And in particular, with the talk specifics to middle management, where people felt like there was a disconnect between a leadership view of integration and then what is actually meaningful to people on the ground. And this was done about over the course of the last year. There is still an incredible source of power and learning from COVID. People really felt like COVID drove integration, and that people set aside any kind of organizational differences, any kind of cultural differences, any kind of resource differences, and got the job done. And I think perhaps over the last year, I've heard less and less of a hook into COVID, but it's still there for us as leaders in the system to dug into and drive forward the agenda. As we've discussed today, we can't forget about the money. People are really clear that there is a sense that integration will just work if you put the right people in the same room together. But of course, it doesn't. It falls apart when the resources aren't spoke about explicitly. And I'll finish primarily, and I suppose there's a huge amount more detail in in the paper, but with a quote from one of the participants here, and I'll just read it out. Coming at it from an idealist perspective, I'd like to get away from talking about primary care and stop talking about secondary care and stop talking about social care, stop talking about mental health, and just think more broadly around care. Patients don't care. They want their problem dealt with, and I guess a truly integrated system would allow people to flow through that and be put into the right box without a them and an us silo mentality. And this came across really clearly from all of our interviews that integration aside, people want to care about people. They want services at the end of the day to speak to what's going to be different for a person. And I think potentially this is lost sometimes in the conversation around integration.
Yeah.
It's around system design. And it's great that we're going out to speak with people shortly, but need to always be drawing back to what is the difference to a person on the ground experiencing services and achieving the longer life expectancy and healthy life expectancy that we've agreed to as an ICP.
Jack, thank you so much for sharing that with us. It's really, really helpful. Is it going to all kinds of different groups and different groups of people? You'll be using that information very widely.
We'll certainly socialize the findings widely. And we've been speaking to the quantitative data that came out of this for a while now. So that's out there. I think this was a survey of our own people. And it's interesting that over the last hour or so, almost all the points I was going to make came out. So there's already sort of, we're listening in some respect, but it will.
So just quickly, because I'm conscious of time. So it's partly back to what Sarah was saying, that we have to have sort of a commonly agreed definition of integration, especially at place, because that's where a lot of the action is. So that's what I was going to say. So this should be informing the place, and the output should be, because I don't see that has to be different. Your priorities might be a bit different. Your outcomes you're looking for might, especially if you're thinking about the distribution you showed us earlier of deprivation and older people. So to my mind, if this is a year's worth of detailed research, it's only worth all the effort if actually we use it pretty rapidly in shaping what we do next. That's all I want to say at this stage about that. One of the things, and then so I can understand it, the evidence says you don't save any money. That's basically what you were saying. Now the truth is we have to save money as well. So that it's not. I don't know that we should. We should say because the evidence says we can't save money. I know that's not what you're saying, but we do have to save money, don't we? So these things are always a bit messy. So there's a real question mark about, well, what does that mean for us then in relation to what our definition is? But I didn't want to get into a big philosophical debate about that. I was just making that point.
Okay, so we're going to go Alex, Sarah, Erica, Councillor Hannigan, Louise. Thanks.
Yeah, I think it's a great piece of work, and it gives absolutely the evidence base, doesn't it, to deliver what we were talking about earlier, really. So I think it really has to, we have to take the stuff out of this to help us drive that change forward. So that first point. Second point, money is key, because if you don't have the resources, you can't make it happen. But a lot of this is not money. Some of it, much of it is behaviour, culture, communication, digital, the whole set of things, isn't it? And connectivity and things. So there is so much we can drive it without that. The COVID incubator thing is really interesting, isn't it? Because there's a national direction there wasn't that we could get on and do the right thing. So we've got to get that. That's back to the leadership piece, isn't it? We've got to get that messaging out there, haven't we? That actually it's okay. Yes, we've taken a tax off, do the right thing. It will help to deliver it. And as you say, not wanting to generate a big philosophical debate about the money, but I guess it's hard to demonstrate. Intuitively, one feels this should save money and certainly it will improve outcomes. I guess it's probably quite difficult, isn't it, to measure the improvement of, does it actually release resources? I don't know if Jack wants to comment, but because intuitively it absolutely feels like it should, because it did stop people going into hospital. And is it because it's very difficult for us to actually pull that out of the piece, really?
I think that the bit of money is if you, from a purely methodological point of view, look at, does this stop an unplanned admission? The answer might be yes. But of course, sat behind that unplanned admission is an unmet need, which creates more demand on services. So we're improving quality of care, but we're not necessarily able to realize the savings from that. I think that's where most of the literature has fallen short. It's been able to fully articulate how we're efficiently addressing needs more holistically and across our population groups compared to just looking at the balance sheet. Just something we'll have to take on as a system.
Thank you, Sarah.
Thanks. There's very few retrospective longitudinal studies on integration, neighbourhood working, and so on, but it goes back to the conversation about digital interventions that actually do demonstrate overall savings. It's really tricky, but we're in a climate and at a time where we find it very difficult to assess anything over a long term, and I think that's really worth considering. My second point would be we are allowed to do the right thing, even if it doesn't save us money, because we're all here to help people make their lives better, and we've got that primary responsibility. And if actually the outcome, if actually we spend the same amount of money in some areas, but we get better outcomes, better experience, better satisfaction from the staff who are involved in those working, then actually that's good enough for me. I'd like us to go a bit further, but that's kind of a really good starting point. And actually the best change interventions, prevention projects that I've led or been a part of didn't start by saying how can we save a load of money over here. They started by saying how can we deliver better outcomes, how can we do this better, how can we make this service run more effectively for people. And they happened to save a load of money. We've got some great examples in things like supported living, where it's great, it promotes independence, people live better lives. We know that people enjoy living their lives more behind their own front door. Happens to cost us a whole load less than residential nursing care for a lot of people with very complex needs. It's like a magic wand if we get it right. And I think we're talking about the the mental health hubs in York, which is a good example of that. Brian Cranner from Tuve and I are very much in agreement that we think that what they may do to begin with is actually find a lot of unmet demand sooner than when it might otherwise have landed. So if there's something that's accessible and it really works for people, people will use it, and hopefully they'll get some support earlier on in their, if you like, journey of need than perhaps otherwise might have done. So it could be 5 to 10 years for some of those individuals before they might have got to the point of crisis. It could have been a year, it could have been 3 months. And we don't know for sure. We've got a very tried and tested model there that we're really committed to. It promotes a social model of care for people and moves us away from a medicalisation, from a medical model. And we think it's really worth trying for a sustained period of time. So I do think there's something about, those key points. We're allowed to do the right thing for people, within the same financial envelope. It might help us if we work better together to actually find and unlock those ideas for what we might do differently, I guess, within that regional pound. And I think that intuitively we do think that we could find ways to find those efficiencies, even if it's just in small ways, to sort of help us to reinvest that into doing the right thing for people. That might be quite idealistic, but actually, I've seen some cold hard cash delivery out of some of these sorts of pieces of work.
It's not. I know the other people. It's not, and I agree absolutely fundamentally with you about all of that. I think it's the same challenge the government's got in the end. Can you really deliver universal services for their health and care? And you've got to make some really difficult choices alongside what you're describing, I think. So I completely buy into the long term. Separately, I'm interested, I'll talk to you separately about that model in York on mental health, because that's definitely worthy of pursuit. But that's all I was trying to get across by crudely saying we've got to save money. The other way of putting that is we've got to prioritise at the expense of other things. This would be the other way to put that.
Thank you. We're going to whiz through a bit now. Erica.
Yeah, just quickly, it follows on from what Sarah was saying, and I think it helps you spend money differently and you manage your demand differently. And we're just looking at the Jean Bishop, and we've got now nearly 6 years of really good data. Where we were on that training hall, and our demographics were really scary, both for health and social care, and we can now start to translate that into how that demand's been met and that money's been spent differently, and there will be some savings for the system within that. I agree with Jack, if you look for the evidence, it's really hard to find in literature, but I think we've got some local models where we can start to draw some of that out.
Okay, lovely, thank you. Councillor Hannigan.
Yeah, I think it's a really interesting debate. I won't cover lots of it again. I think the point Sarah made was really valid, that if it improves the patient journey, it's worth doing. And I think that really does go without saying. This notion of taking cost out, I mean, I've been around the public sector a lot of years, and trying to link an action to a reduction in cost is extremely difficult. The more complex the system gets, the more difficult it becomes. Whatever you do, don't tell Wes that integration won't reduce costs, because he won't like that. But when you look at cost, in a health environment, I suppose it's demanding complexity, isn't it? When in a nutshell, and the challenge becomes, how do you reduce demand and complexity? And perhaps that's where we really do need to focus our efforts.
Yeah, back into our prevention agenda.
Absolutely, it is.
Yeah. Louise?
The points have been made, so thanks.
Okay, lovely, thank you. Jake, you've sat so patiently. Now is your big moment. We're going to educate us a little bit around the outcomes framework, please.
Yeah, first thing to say, Sue's apologies. Colleagues won't have had the slides yet, except Sue, I think, has had them, but I only sent them through yesterday, so we'll follow through after the meeting today. And there's quite a lot in there. And if people get a chance to digest them, I'd be really happy and keen to get your correspondence sense of what works. There's quite a lot of detail to get into, but what I thought I'd do today is just to take you through a couple of the headlines from it in 10 minutes, if that's
not managing time very effectively today.
So we talked about the outcomes framework at this group before. Essentially, it was a commitment that we made in the strategy before the strategy refresh around being able to measure, what we're doing, measure the impact of what we're doing. And the statements in the banners around the wall come from the strategy. Those are the commitments expressed around statements on how will we know if people are living well, how will we know if children are starting well. What we've been challenged to do is to try to measure, to look at a way of measuring some high level outcomes against these areas. And since the original strategy, we've developed this focus on what are called our 4 big health outcome areas, plus this ambition, this golden ambition around radically improving children's health and wellbeing and care. So the scope of the outcomes framework is really looking at these areas on the screen. So it's our life course themes, and it's our children's ambition, and it's the 4 big health priorities. And those are by no means the only things that we're doing as a partnership, but at a kind of very high level, we're looking at how we can measure whether we've made a difference over a longer time period, not something we're tracking on a weekly or a monthly basis through our performance meetings that we have through the ICB. This is actually trying to step back and say, where are we trying to shift the dial for some of the big health outcomes that we're looking at? And apologies, a bit of a wordy slide, but just the key principles are quite important here. So focus on those 5 key priority outcome themes. The measures, and this is a bit of a challenging one because the measures are chosen to reflect what are the key programme priorities and the specific actions under each theme. And I'm conscious that there's some work to do on fleshing out, what does having a focus, shining a light on frailty or on mental health mean. One of the things we're going to do differently, which is where you then look at what have we changed in terms of outcome measures. But that said, I've been following up with conversations with each of the leads to really test out, from their perspective, whether it's the Cancer Alliance or our Frailty Centre of Excellence leads, what are the things they would think we should see some sort of shift in over a 3 to 5 year period. There is some value, and again, this is always going to be an oversimplification of a whole raft of work going on, but there's some value in having something we can look at on a single page. 4 to 5 measures maximum across each of these themes that give us a sense of variation and direction of travel. We're keen that we're looking at outcomes rather than outputs and activities. A lot of what we look at in the ICB is performance measures, their activity metrics, inputs and outputs, rather than outcomes per se. We're really keen that we benchmark, and I'll come back to this a bit later on in the presentation, that we're able to look at variation across our places and ideally at sub-place level, and even more importantly, over time, we can connect it into the work that we've talked about today going on at neighbourhood team level and in communities. We're really keen that we can look at dimensions of inequality, we've talked about in the partnership before, and that we are not duplicating all the things that we look at, the hundreds of metrics that we look at on a monthly or even more frequent basis across the organisation. So we've got 5 broad themes. We're also looking at life course, and we've put together a basket of measures that essentially try to reflect the statements in each of these 4 areas. It's quite difficult for some of them, but we sort of get a sense, it's a bit more fluid, but what are the kind of things we can measure that will give us a sense of whether we're achieving those? And conscious, quite a few of those will probably end up being qualitative voice of lived experience type measures, which we're starting to integrate in, but haven't really got a sort of comprehensive view on at the moment. And then the last bit is really importantly that one of the key parts of this, probably as important as the measures themselves, is that colleagues can see how the work they're doing, the inputs, the activities, the work through collaboratives and place is contributing. What's the logic for how the thing that we're doing in this practice or through this work in the hospital will in some way have an impact further down the line on one of these big ticket outcomes. So just to give you a sense of where we've got to, and most of these you probably expect to be in there. So we've got our overarching aims on healthy life expectancy, both closing the gap and making an improvement overall. We've got measures around mortality from cancer and early diagnosis. We've got measures around infant deaths, emergency admissions for children, children's development, educational development, overweight and obesity, measures around frailty, falls admissions, for example. Polypharmacy, one of the areas that's come out through conversations with frailty leads. We've put some markers in there, challenges around frailty index and how we develop an approach to doing that consistently, and particularly for mental health and children's mental health, good measures on paired outcome scores for what's the change in terms of outcomes for children or adults through being involved in treatment. There's some data, but we haven't got robust flows coming through at this stage. And then similarly, I won't go through these, but there are a list of metrics underneath each of the start well, live well, die well, age well frames. So we can put all of this together in a dashboard. We've got red, amber, green colouring. You can look at it on a page. It will give us a sense of how things compare to England, and you can put little markers in around direction of travel. Now, before I came to work here last year, if you'd asked me what it looked like for Humber and North Yorkshire, I probably could have drawn most of these, because it tends to be whole North East Lincolnshire tend to have poor health outcomes. York, North Yorkshire, East Riding tend to be better. So I know that's a generalisation, but in terms of the challenges for the systems and the populations that we serve, there's something about moving away from just comparing ourselves with England. So we've been testing the idea of using demographic peers, and local government colleagues will be familiar with this in their sectors. There's quite a lot of work goes on in the NHS in this space. So just to flesh this out a little bit, these are nearest neighbours for North Lincolnshire, ranked in terms of order of similarity. So this is a sort of 15 most similar in terms of the demographics, type of geographical area, urban, rural, etc., and how CVD mortality rates from 75s compare. So quite a lot of variation, but probably if we benchmarked or RAG rated, if we want to RAG rate for all of our metrics against similar local authorities, that might be more meaningful. So what's a reasonable challenge for York to move towards, rather than just being better than the England average, or what's a reasonable stretch for whole or North East Lincolnshire? What we can do beyond that, though, is to say, actually, would it make sense to create an ambition for us? Because I said we can decide on outcomes, but we haven't said what does reducing mortality for CVD mean. What are we saying we're going to reduce it by X or Y rather than just monitoring the rates? And I think those are conversations we should probably be having. And maybe using demographic peers is a more meaningful way of saying this is something we should be aiming at, because we're probably not going to reach the national average for everything, or we should be looking at stretched but achievable, challenging but achievable. It also potentially there's something that brings out the figures in a bit more of a meaningful way. And I know, Sue, you've talked before about having things that we can communicate more effectively with externally and across the organisation. So we just did an example here around an equivalent for each local authority, each place, its average of its best three benchmark peers, statistical peers. So the average of the three most similar local authorities to East Riding, to Hull, to North East Links, and to look at what their rates were. So we said, actually, if all of our places had the same CVD mortality rate as the average of the best three statistical peers, how many fewer deaths would there be per year? And it's about 500 per year. Now, there's a lot to unpick in that, and similarity of the best three. Some local authorities are quite fairly unique, and you can go through these with some time, but there's a full list of the demographic peers for each of our six, and they get statistically less similar as you go down. So you can pick and choose. I think in practice, I know a lot of local authorities will just know which local authorities they tend to look at. Who do we tend to compare ourselves with? Because we know they're fairly similar. Does that make sense for people? And then we've got something similar for children's, and there's some quite well used children's services benchmarks that local authorities use that we've put in here as well that we could use for some of those measures. I've put in a couple of slides on inequalities because, again, as a commitment, we have some indicators, particularly around CVD, from the CVD Prevent audit, which give us really granular data to benchmark. And it's not just geography. We can look at comparing outcomes on CVD for people with learning disability versus those without, or for people with SMI, severe mental illness, and those without, or for ethnicity and for deprivation, obviously. So that kind of granularity is something that was really keen to pursue. And then finally, just to say, as I mentioned at the start, that the outcomes give a very high level picture in this, and one of the keys is that we're able to connect it back into the work that we're doing across our work programs and places and collaboratives. So just as an illustrative example, these are the metrics that we've been developing with Jack for the population health and prevention work stream and committee that Louise and Julia Weldon chair. And it includes a whole lot of measures, some of which are activity and inputs and process measures, which is fine. And we can look at those on a monthly basis. But actually, we can pick out the ones from here and they're only one of the inputs, but these will help contribute towards some of the things we're trying to do, whether it's around smoking, cancer mortality, CVD mortality. So I'm really keen to pick this up and try to do that kind of logic modelling across all of our programs to say, what are the things that we're doing in our JFP, in our collaborative work programs in place, and how do they contribute towards these high-level outcomes that we're trying to move the dial on over time. So that's it. Essentially, we're moving forward to just firm up. We've got a few markers, particularly around mental health, that we're trying to work on with colleagues. We have got quite a nice interactive Power BI dashboard that is similar to the women's health one, if people have seen that we developed, that I can come back and talk about at a time, but we're just trying to get everything into there so it's a bit more interactive and people can explore it. I mentioned about the logic model, and then again, as I said, keen to drill down and create the metrics at smaller geographies, particularly place, and as I said, building the voice of lived experience, intelligence and insight, particularly into the reports around the life course themes. I'll stop there. Hopefully that's helpful.
Great, thank you, Jake. Really comprehensive. I did say to Jack and Jake when they arrived today, they are like our secret. They're a secret weapon, aren't they? They know things that other people don't know. And actually, we should be sharing this really very, very widely amongst our partners, and our partners should be very keen on receiving the information that you share. So thank you. There are questions, good, but we are going to gallop through the questions, so make them snappy. Starting with you, Katie.
Yeah, just a couple of quick things. So yes, in terms of comparators as local authorities, we use our SIP for comparisons. So that's something we would look at anyway. Also, people with lived experience, our experience more recently around some of those indicators in North East Lincolnshire is when we went and asked people with particularly mental health, we as a set of professionals would never have come up with actually what would make a significant difference in helping them to support with their condition, and therefore lived experience is really the key for us, because generally people do not prescribe themselves expensive, costly.
No,
they know something really simple and straightforward, and we've got to make sure that whatever we do is co-produced and their voice is centre of it, because that will make the biggest difference in terms of supporting them to make the changes that we need to get better outcomes.
Thank you, Katie. Yes, Sarah.
So we had a bit of a conversation about this, didn't we? And yes, in terms of the statistical nearest neighbours thing, it's much more sensible to take a look at those. Obviously, we talked about the adult social care outcomes framework, and I met with Jake. One of the measures on there that we're trying to reduce is the number of people we admit to care homes. If you look at that data, you'd think York is doing pretty well, but actually it excludes self-funders. So, you know, somewhere where you've got higher property values and home ownership, you're going to see potentially lower numbers in some of that. So there's really good reason for us to think a bit about that. I couldn't see it because it was too small, but did you get any of the ASCOP measures in there, Jane?
I haven't yet. It's down as one of the ones that we're still trying to pull in. Yeah.
So can I just be really indulgent? I mean, clearly I'm totally biased that this is absolutely the right thing that we should be doing as a ICP, to have public health intelligence at the heart of everything we do. Not every ICB has this, or SES has this, so let's just recognise the beauty of it and use it in every way we can.
I'm in agreement. Peter.
Very brief. And this is brilliant, because we were only socialising these priorities back in the spring, and already we're now starting autumn with this power on. The commitment in our strategy, just to take us back to what we've committed to, is we are outcomes led. That's the first bit. And then increasingly preventative in our use of resources. So as we take this work forward, and our thinking around outcomes led medium-term financial planning, it starts to wash back in, because we'd start to see that drive towards more preventative measures, because we've got the intelligence to know we're on the right track.
Yeah, thank you. Gary, did you want to say something? No. Are you just moving your pen? Great. Well, thank you both very much indeed. Some nice accolades for you then. Now, for our transport and travel folk who come along specially, I'm sorry we're running so late. I don't think we expected to run as late as we have. I think we can run. I think we can run till 4:15. So let's give this item the time that it properly deserves. I'm going to welcome Gary Sainty, who leads on much of our work with the voluntary sector, and Chris Dexter, who I spot comes from Yorkshire Ambulance Service. I'm sure you're going to introduce yourselves. Can we get going?
Yeah, so Gary Sainty, head of BCSE at the ICB. We have got a presentation with some slides, not coming up on the screen. Whilst we're just doing that, I have got a couple of colleagues from the BCSE sector that are joining us, because let's be fair, you want to hear less about what I've got to say and more about what the BCSE colleagues are actually doing community transport and are in the thick of it. So if I can get Owen first to introduce herself, then Liz.
Hello, Jane, welcome. You're muted, Jane.
Hello, I'm so sorry. Getting everything to appear on the screen is difficult. Hello, I'm Jane, and I'm from Humber and Wolds Rural Action.
Liz, are you coming in next?
Hello, Liz. Can you introduce yourself, please?
Hello, hi. I'm Liz Lockie. I'm Chief Officer at Hambleton Community Action, based in North Yorkshire.
Okay.
Have we got Jane Iverson? Sorry.
I think we might be missing Jane at this point. I will send her a message. But yeah, Jane Everson will be here from East Yorkshire Community Transport.
That's fine. That will help a little bit in timing, I think. possibly. Can we skip on to the context slide? So I won't take too much time. I just wanted to say a couple of things off this slide. So from a VCC community transport point of view, it's not just a taxi service. It's not just about getting people from A to B. Actually, there's a much wider service that is provided with benefits to people that it serves. And on the next slide, there is a video, which we won't play today, but I welcome everybody to have a look at that. And that just kind of showcases better than I could do in words in terms of what a VCSE organisation delivers. And it's a North Yorkshire example for those that are North Yorkshire. I will pick up, because money is always mentioned in everything, the investment bit, and VCSE organisations and community transport have a number of sources of funding. And also, I think there are different levels of funding that goes into community transport across all 6 places. The only thing to point out on that is very little of the community transport funding comes from health, whereas the majority of the community transport journeys are health related.
Yes,
There's a little bit of an imbalance there. Finally, on the VCSE collaborative, as I've mentioned, we've put together, one of our priorities is on community transport. So we're going to work with and support the development of community transport over in North Yorkshire. And as part of that work, we have commissioned some mapping, which Jane, Liz and Jane have led on for us. So I'm going to let them go through a little bit of their findings and a little bit of a temperature check, should we say, in terms of what's happening in community transport. So go to the next slide. Well, next slide, one after that one, and then I'll let Jane come in.
Perfect, thank you. So conscious of time and aware that you can all read, what I wanted to make sure was that you understood that this mapping exercise isn't covering absolutely every aspect of community transport. We've focused on the type of services that people can use for transport to health appointments. That's not to say that the rest of community transport doesn't have health outcomes, because it really does. Social well-being, transporting people around to stuff that's nice to do helps keep them well. So we really wanted to kind of show that what we're not covering here is the absolute full gamut of community transport. But in the ICB area, you've got 27 providers in total covering the whole area. The majority of us are in North Yorkshire. It's a lot bigger, so you wouldn't be too surprised. There's a variety of different services provided, and generally speaking, these are developed by community transport organisations to reflect the needs and the type of things that are missing in their community. So it doesn't duplicate other forms of transport. This is to fill gaps in between bits and pieces. If you want to show the next slide, this shows you where all the transport providers are based. We will have a slide that shows you which ones cover which areas, but it's far too complicated to put on screen. It's going to be a zoomable Google map. Some of the questions that were asked in this mapping exercise, we will be giving you the answers in the full report. I don't know able to tell very much from the answers. I selected a few bits of that on the next slide, if we can go to the next one. Which basically, there is no average organisation. They are different sizes and structures, but with a predominance of registered charities. There's a range of different sized organisations. The smallest reckoned their costs for their community transport aspect was about £10,000. We have one very large organisation that's nearly £1 million per year, and they do solely community transport, really. So it's, again, difficult to give you an average. Most of the funding that comes to those groups is not from health, as Gary said. Where they're fulfilling contracts, where there are grant funders, they must deliver on that, not necessarily health outcomes. We would all hope that they align, but we can't absolutely guarantee that. There is a really wide range of sources of funding. Local authorities are really important to some of the community transport providers in terms of both their funding and the way they organise themselves, but that varies massively across ICB, and I think Liz might say a little bit more about that. Notwithstanding the diversity in the community transport organisations, we are experiencing a lot of the same challenges and issues, and the Community Transport Association nationally has just released a report that actually echoes a lot of the findings that we have from this mapping. One of the particular ones that I think all of our community transport providers would not forgive me if I didn't mention it was the spike in demand that everybody's experienced relating to non-emergency patient transport changes. And we know that that's likely to be something that comes up again next year. Our eligibility criteria is pretty standard across the piece. There's not much variation. Basically, we're aiming our services at local people who can't use public transport for other reasons, and we know that there's a diversity of reasons. I think you can see on the slide we've put some details about that in there as well. I think I'm going to hand over to Liz from Hamilton Community Action for the next bit.
Thanks, Jane. So if we could go to the next slide, please. Okay. So as Jane said, we've got some massive variations in terms of the types of transport that's and the way those are organised across the patch. And the example on that slide at the top, go local. So in North Yorkshire, as we say, we've got the highest number of community transport providers, probably with a lot of the variety in there in terms of how that's delivered. There is a collaborative piece of work that happened a few years back between the community transport organisations and North Yorkshire Council, and that's Go Local, and that aims to provide a place that people can find what community transport's available because of the levels of complexity and the amount of rurality involved. But in terms of challenges, and I'm very sorry to bring this up because I know it's something we always get accused of in the VCS, that we're always asking for money, but money, funding. It can be really, really challenging to get funding. As Jane said, donors only want to pay for the things that they want to pay for. And in a lot of cases, grant schemes would argue that community transport is a form of statutory requirement. I'm from North Yorkshire, where it's fair to say that community transport is used as a quasi-public sector because of the lack of quasi-public transport, because public transport is so sparse in some places. There's a lot of competition for grants, and of course costs are rising. So some of these community transport providers have paid staff, some are entirely volunteer run, and most a mix of both. The local authorities, because there's several over the footprint, how they're involved in community transport varies sometimes quite considerably in terms of whether they provide for themselves, fund certain services, or, as I say, consider community transport to be part of the wider public transport offer. So some of the variety in that, for example, demand responsive Medibus, which is specifically tends to be around health, shopping and retail services that are contracted. Some community transport provides home to school services, and again, mainly in North Yorkshire, volunteer community car schemes, which is where volunteers are using their own vehicles. One of the challenges with that is that that is not funded at full cost, and we have recently seen some service withdrawals and gaps, or organisation closing their offer to new members. So that can cause considerable challenges where there is no alternative. There aren't taxis, there aren't buses, for example. We have some uncertainty in terms of the impact of the change to mayoral combined authority. Another challenge, but it's linked, is the fact that as demand increases, services can be quite limited because of volunteer drivers. I sometimes flippantly say to people that there's often an expectation for statutory providers that there's an ever-expanding number of volunteers because there are an old ageing population and most volunteers tend to be older. There's almost an assumption that we have a stack of volunteers sitting in a cupboard ready to be deployed, but I'm afraid that's not the case. Volunteer recruitment can be very challenging because of changes, particularly around COVID. We've seen demographic changes. We've seen volunteers doing more caring for older parents, for families. People don't necessarily have driving licenses that allow them to run for minibuses, and some of the training and licensing requirements can also be a barrier. Lift sharing could significantly reduce pressure on volunteers. It needs exploration. Part of the changes that we've seen in terms of demand are about an increase in medical appointments and needs. Eligibility criteria, as Joe mentioned, has tightened. That's caused a spike in demand for community transport. I think it's worth stating that eligibility seems to be mainly linked to condition. In terms of how community transport responds, there's probably an argument for capability related criteria being explored. So, for example, we may have passengers that meet the criteria for patient transport, but actually could use community transport services. But we also have passengers where they're not really suitable for community transport, where it's volunteer drivers. So mainly around mobility, risks of falls, for example, comes with that. We don't necessarily talk to each other as much as we like. I think Jane and I found it really useful to compare and contrast across the area during this project, but there isn't typically that level of co-working between the community transport providers. Again, there is some working together, but although we have similar frustrations and similar challenges, there isn't always the time and resource to work collectively. We have pockets of good practice with that. So, for example, in Hambleton and Richmondshire, we have a rural transport and access partnership that brings statutory and local community transport providers together, but that's not reflected across the rest of the patch. Final challenge really around collaboration with health providers. So one of the big challenges that we tend to face is around last minute appointments or cancellations, because those things can be very difficult to turn around to do with our structures. There is some potential for clustering appointments and also for looking at how appointments time could be worked based on how far people might be travelling. So, for example, if you have to travel from one edge of the area to another, that could be a 2 or 3 hour journey, and your patient may not arrive in the best state if they've set off at 5 in the morning for an early morning appointment, for example. We do have a small pilot that is being used with ICB Health Inequalities funding that's looking at doing some clustering. But again, it's not clear whether that's something we'll be able to explore further and expand. And at this point, I'm due to hand over to Jane, and because I can't actually see whether she's here at the moment.
I am here. I've made
You're there.
it.
Fantastic.
I'm here, I've made it.
Congratulations. In that case, we go to the next slide, and I will hand you over to Jane.
Thank you very much indeed. Sorry to only have just joined you. I've had a bit of a messing around, but I'm here anyway, and I really welcome the opportunity to speak to you about community transport. Your patients obviously very often become our passengers, and I think to achieve the best, we need to understand your process better, and you, our potential and our limitations as well. If we can start to have a dialogue, then I believe the first bullet point I have on my slide, we can start to achieve. And secondly, better communication. That also could mean, fewer missed appointments as far as you're concerned. But better communication, if I can highlight, for us at Community Transport, the change in criteria for patient transport. Those patients, although not using patient transport, came to us at Community Transport. They still needed transport to get to hospitals. And it would have really helped us if we could have been better prepared for that. So again, that sort of communication and working together. All community transport have seen an increase in their demand to get people to medical appointments. But our work is varied. It's much of it is about being proactive, about keeping people away from hospital longer. But we're sort of limited. We have a number of vehicles. We only have a limited number of vehicles, and we only have a certain budget, and we also have contracts that we have to honour as well. And if I tell you to renew one of our buses, it costs us about £100,000. You'll see that it's something we have to manage very, very carefully. So I think sort of better communication, as far as I'm concerned, is at the bottom of this. I would really welcome that, and I welcome the opportunity to talk to you today. But to possibly end on a bit of a more positive note, and what I can say is sort of a glimmer of hope, then something that happened recently, and that's since we've been in touch with you and talking to you, and that was a contract for cataract treatment, which was at Grimsby Hospital and being moved to Goole. And because of the communications we had, the problems you were facing about getting some of your patients from that Lincolnshire area into Goole, we were able to talk to you about that and put you in touch with somebody from community transport. And I hope we may well have found a solution. Also, what we do need and what we would ask is that you would consider, wherever possible, looking at block booking appointments, so that when we're taking people in from these rural areas into your hospitals, we can take a bus full of people in that can actually attend a whole morning appointment, a whole afternoon appointment, and take them back. At the moment, we're very often running about taking 1 or 2 patients from here, 1 or 2 patients from there. It isn't cost effective. It just doesn't make sense. It's not economical. It's not good for you. It's not good for us. So I think by working together, there are so many opportunities where we can make for a better service, a more efficient service. It would certainly help us to meet your demand, and may help you too.
Jane, I'm just going to stop you there. We've got your message really loud and clearly. Thank you very much indeed. We are really limited for time, so I'm going to hand back to Gary, and I know we have a colleague from the ambulance service here who I think is going to want to speak to.
Yeah.
So to you.
Thank you. Thank you all for doing that. It's really useful. If you just click onto the next slide, which I will go through, just to, I know we'll transfer across. So this might form part of the discussions. I suppose what I'm going to just quickly say is on this slide, it's not just health responsibility. There is something for community transport and the VCSE sector to do, which we will lead on. There is, you know, a message there in terms of health. If we need the service, then we need to pay for it.
Yeah.
And I think the one thing I would pick up off this slide is, in my mind, I think, and for all the conversations I've had, we almost need a framework of having the right transport for the right person. And we probably need a smaller group to work through that. So we'll leave that there.
Okay. And the ambulance service, do you have a contribution you'd like to make, Chris? Or an observation?
Well, I've got a presentation which I
Well,
don't.
you've got 14 minutes.
Okay, I will keep it as short as I can.
2 or 3 slides that you really must share with us.
That's fine. No, that's fine. So if we can move through this slide, please, and to this one, it really demonstrates the model that we've got. I suppose if you look at the scale of what we do across Yorkshire, we're delivering just under 1 million journeys a year. You know, in terms of content.
It's across. Do you mean Humber and North Yorkshire?
Humber and North Yorkshire is just over 300,000 journeys a year. So that's for the whole region.
Patient transport journeys.
Patient transport journeys. So they are a mixture of planned care appointments, treatment appointments, and discharges on day, non-emergency. And as colleagues have said, but for people who meet an eligibility criteria, and I'll come on to that shortly. If you look at the pie chart there, that just demonstrates the split. So the blue bit of cheese really is what we deliver ourselves with our own employed staff and our own vehicles. We do utilise a framework already. We've got experience and expertise in doing that. We have quality frameworks that providers are required to meet. Many of those are private providers. Some of those are voluntary sector providers or community transport providers. And we also have our own voluntary car service as well that delivers a number of those patient journeys.
Okay.
Could move to the next slide. Thank you. Okay, that just gives an idea of the requirements that we have in terms of the specifications. Go to the next slide. Sorry, it's the next slide. Okay, so colleagues from voluntary organisations, community transport organisations have already touched upon. There was an NHSE review, reviewing the whole of patient transport. That really was as a result of a lot of failed PTS contracting, and we've experienced some of that in this region, in terms of the providers that have failed to deliver the quality that's required, or a failure in that contractual agreement or whatever that may be. So that was the purpose really, to look at it, but also to look at other areas such as net zero, better procurement and eligibility and patient eligibility for those services. So we can perhaps go to the next slide, just on the basis that the new eligibility guidance was published in May 22. got a slide here just to show we are investing. This isn't cheap. So colleagues have mentioned how much it is for a new minibus. I think the infrastructure around charging vehicles is colossal, and we need to look at that. So I think that's a good collaborative opportunity really with ourselves and local authorities to look at electric vehicle infrastructure and charging. Yorkshire Ambulance Service will be the largest provider of electric vehicles of an ambulance size, not cars, we're talking ambulance size vehicles, and they're arriving in the next few weeks. And we will have, I think, 10 or 11 of those 35 across this ICB area as well. So out of Scunthorpe and out of Hull, Hamburg Road there as well. So we've got the infrastructure. So they will be going shortly. Clearly, the rurality will have some impact as to where we place those vehicles. Next slide, thank you. Just in terms of where we're at, demand is rising hugely, and I think we do need to escalate this, that we are now seeing a rise in demand of more complex patient demand. So this isn't as a result of eligibility implementation. We're genuinely seeing more complex patients of higher acuity with more mobility challenges coming through, and that's becoming unsustainable in certain parts in relation to the funding that we're having, and that's most acute across Yorkshire in this particular ICB as well. And very interesting seeing your slides earlier, in terms of where we're seeing those problems, or not problems, but those increases in demand and the challenges that we're facing, and the distances that we travel as well. So we're seeing an increase in complexity, which also drives down some of the efficiencies that are possible as well. Happy to talk through that in more detail with people. We've done a lot of analysis and we're working with colleagues in the ICP. So just in terms of, I suppose, the three areas I just want to touch on were around an awareness of the pressures that we've got on services, the national intentions around eligibility. There is a piece of work that's happening. Colleagues from the ICB are working and doing a consultative exercise at this point in time, to advise what those eligibility criteria will be. So colleagues from the voluntary sector, we do need to engage with you, and colleagues from the ICB do as well, as to what those will be. I think what you were referring to earlier was probably previous eligibility implementation, which would have been back in 2019-20 really, when last procurement rounds really started. And just in terms of support, we're looking at trying to standardise. We operate just in this ICB 4 different contracts with 4 different SLAs with 4 different scopes, different times of day, overnight services for some, not for others. So we're looking to standardise not just in this ICB, but right across the region. And we think that will drive efficiencies as well, things like some automation for planning, as colleagues were talking about in terms of picking up, maximising the seats we've got on vehicles there. If we could look to standardise right across the region, so we're doing some work there. So one of the asks we're asking from yourself is just to note that, and there's an executive leadership board which has all 3 ICB officers or their deputies there. They're looking at things they can do on a collaborative basis, which this is one of those.
Okay, thank you. Thank you for coming to talk to us and tell us that. So we wanted to do this deep dive into patient transport because we know it's kind of nobody's job, is it? People run away, don't they? It's VCSE, it's people do it for themselves, it's the ambulance service. But we do know that for many of our patients and service users, it's one of the most important parts of their experience. And I know from looking after my own mum and dad, when you've got to go to the hospital, it's a day's activity, getting an elderly person ready, out, gone, do the appointment, find a wheelchair, all of that. So it's an important part of what we do, and it's going to be an increasingly important part of what we do. And there's no point us having an amazing blueprint for the way we might want to adapt our services across our geography if we don't do that in a way that enables patients to access services, even if it's slightly different. So this was an important piece of work to work out how the ICP might help support the delivery of patient transport services. It's a bit more, there's a bit more of it than I might have thought. So very, very grateful to you for your presentations. But I think this is very much the territory of the Integrated Care Partnership, where we bring together different people doing different things. And it sounds a bit as if there's already some work going on around that, Chris. Am I right?
That you talk about the whole of the region.
Yeah.
With the 4 ICBs, Chris.
The 3 ICBs.
Three, I mean, sorry, I'm thinking northeast. The 3 Yorkshire ICBs.
3 Yorkshire
Yorkshire
ICBs.
ICPs. Okay, the Yorkshire Ambulance footprint.
Just to check in, because there's a lot more, isn't there? And we're pressed for time. This is a step, isn't it? This isn't the final report.
For us,
this is the mapping exercise.
Yeah.
It gives us some sense. Because the piece of work that's really important to me, that seems to me, should I say, to the people we're serving, not to me, is some alignment. Picking up what colleagues on screen were saying, we're in a world where I think, in this arena at least, collaboration's important. And then prioritisation within that. But I sort of do understand the voluntary sector, I think, fairly deeply, without boring you with details as to why, and so on. But and then how that connects to what we've just been hearing from Chris, and specifically how that connects to where we're going to provide services from under the blueprint. So, I mean, in a sense, that's the point, isn't it? If you want to sort of turn what we're hearing here into something very specific for the Humber and North Yorkshire footprint. And what struck me is, you see, I'm not sure how many, and it might be, I might be mistaken, some of our more rural areas are not sure going to have that many charging points. Quickly. So, what's the partnership model? How are the results? Is there a single set of resources that are being devoted to this? And can we have some strategic oversight? I won't bang on, but that's the point, really. I think for an ICP, so there's lots of other factors here at play, I know. So I'm just saying that's probably the next thing, isn't it? In aligning,
what is the time frame of the work?
In aligning this particular issue, with the work of the proposition around our strategy. So the other bit you can't ignore here is some transport needs might be significantly reduced or eradicated by the use of technology.
Yeah.
In fact, it should be. So I think you've got to sort of sit some of that alongside what's emerging here. So I think it's just a steerage, really, Chair, in terms of where this needs to go next.
In terms of
you might have already had that in mind, but
yeah, in terms of timescales for the mapping piece of work and the report, that's due out. Literally, this meeting's come maybe 2 or 3 weeks too early.
Okay.
So
it's sort of on to, well, what do we do with it?
Yeah. The VCSE collaborative and our priority obviously is a much longer term thing, and I think one of the conversations we were having was, how do we keep the momentum going of connecting voluntary sector into health and care and creating those things? So I think that's going to be
it's a bit like somebody was saying earlier, isn't it? We shouldn't be thinking that, and I know you're not, but it doesn't matter if it's voluntary sector or the ambulance service. The issue is, what are we providing to those communities and patients? Does it matter who's providing it? It's another version of integration, you might say. But, yeah.
So I think that's what we need to do, is take the report, use that as a stepping stone, but I think it's a series of stepping stones to make sure that we've got integration between BCSE and community transport and health colleagues to map things. I think the mapping is just one element of a much wider piece of work.
One of the things would be really interesting in the mapping, to me at least, I'm not obsessed with money. How much do we spend on it? What's the totality of the spend? What's the size of the workforce that we're talking? I mean, those are the sort of things I think, if we're looking at things collectively in this room, and I'm reflecting back, it's not about what you've done, I'm reflecting back some of our ongoing conversation about how we reposition the ICP, but that'd be really useful to know, wouldn't it, what the spend is.
Just one final point on the investment bit, because
for example,
we've mentioned it quite a lot, and obviously more funding would be welcome, I'm sure, but I think one of my challenges back to VCSE colleagues when we did the webinar was, this is a system-wide thing, actually. So when we're talking about resource, we're not necessarily saying, does health have to pay for all of this lot? Because actually the local authority fund quite a lot. So we are trying to make that difference as well in the reports to what's local authority.
But you might say, I mean, I think, I'm sorry, colleagues, you weren't in the earlier bit, that when we're looking at our data, which is really quite sophisticated about where our older people are, or where our most deprived communities are, even with the money that we currently spend, we might want to spend it differently in this arena. That's the sort of point that making, and or in selectively invest more by going back to, I think it was Jane's point about we could always do with more money. Selectively target areas for that reason. So I think that's jumping is into where I might go with it, really.
Okay, so what's next then? What are we going to say, Chris?
There's a couple of points, and apologies because it does feel like we're talking slightly separate schemes or programmes. From a patient transport, NHS funded transport perspective, there's a current review going on, a programme of work to implement new eligibility criteria for the 1st of April. Okay. Then there is a piece of work where basically all contracts across all 3 ICBs have had their end dates more or less aligned, perhaps with the exception of North East Lincolnshire, because I know that's delivered by another provider, but the majority, 80% of
most of it, isn't it?
Yes, will be for 2025, September 2025. So there's currently under provider selection regime some consideration as to how the procurement of those will happen going forwards. There was a change in legislation through Parliament about competitive tendering versus a direct award, and given they're looking at almost region-wide or ICB-wide commissioning, they're reviewing the whole procurement process. So that piece of work and that programme is starting now. It's been led or hosted by West Yorkshire. It's got programme leads on from each ICB.
I suppose what I'm getting to is what's the next thing we need to hit? We're going to hear at the ICP. When should our next touch point be on this topic?
Well, what that will do is it will tell us exactly what the offer is from the ambulance service, because that's the criteria being standardised, and how much is going to be spent on it. Okay. Amongst other things. So it's a component part of the point you were making. It's not just the NHS, is it? It's a broader piece.
Yeah, I think for me it is that piece that put on that final slide is the right transport for the right people, and almost having that as a bit of a thread. That's got to be for us the next step. And I think we've had pre-conversations as of colleagues, and I think there's maybe a few of us and colleagues that are not in the room, Penny Gray and what have you, that are leading on to that consultation, that maybe need to get back in a room and have a bit of a conversation about that, bring back to a future.
So I think Helen wants to comment, and Peter. Helen.
Yeah, thanks. I mean, I think what we've got to do is dovetail all of this. You're right. I think it's highly likely that as a result of the eligibility criteria, some people are currently getting transport and therefore we've got to make sure that as a system, people are still able to get to their appointments, because otherwise we're widening the inequalities. I think that's the key piece of work that we've got to make sure is answered. Whether that's funded by us or through other things, I think it's a different question, but that's the exam question, isn't it? Making sure people can get to the appointments that they need to. I think there's a broader piece there, increasingly, again, linking in, because this is feels very much about planned care, but I'm also increasingly aware that on the unplanned agenda, blue light services are increasingly becoming blue light, and we're getting lots of examples where people are being called out to what they don't class as true emergencies, but actually people have got no idea how else to get transport.
That's a primary care issue.
So I think there's a third element to this piece of work ultimately, which is about actually how do we start to pick up important and urgent but not emergency transport as we move forward as well, because I think that also is driving inequalities, poorer outcomes, and then hospitalisation when we don't act fast enough.
That's a really, really good point. I'm going to Peter and then to Sarah, and then I think we're done.
Very briefly, mapping is one thing, but remember there are probably resources we haven't tapped into. For example, most local authorities have huge fleets of minibuses which do school runs in the morning and do very little in the middle of the day. And secondly, we mustn't forget that the new players on the pitch with the mayoral combined authorities will have responsibility for integrated transport policy.
Is that applicable from? Is that still? Is it going to be legislated, or is it?
Well, it comes with the deals. So as the deals implement. So I think Stephen's point about how does this get coordinated?
Yes.
And in a sense, we need to be thinking in a broadest way.
Yeah. And Sarah?
I was going to mention Devo, and we need to talk from there, but also just presumably the impact assessment of that change to eligibility criteria will have teased out who's going to be impacted and who won't get transport, who might have had it in the past. It might be useful to see that, I think.
Okay, and we'll learn that by place probably, will we? Is that how we'll discover that?
I think each ICB is led on it in their own area. So whether they're back to each place within each ICB, I can feed that back. I can find that out for you.
Thank you.
But I know they're pretty good, so I could share those via yourself, Nikki. Maybe. Yeah.
I don't think there are any matters of any other business, were there? So thank you very much indeed to our guests, Jane, and Liz. Thank you to Chris. That's a conversation I very much wanted to have at the ICP. I think it leaves a few questions unanswered, doesn't it? And opens the way for a bit more work, but I'm pleased about that. I think that then takes us closer to the place that we want to be. Thank you all very much indeed for coming along this afternoon. I appreciate it. Thank you for supporting us, and have a safe journey home. Thank you.
Thank you.